Welcome to the Feeding Pod. We are very excited to talk everything laryngeal clefts today. And I have two guests with me, Carolyn Schultz and Caetyn Groner. They come with us with a wealth of knowledge about laryngeal clefts, both from their personal experiences, from advocacy work, and also with Caetyn being an SLP who serves on the board at the Laryngeal Cleft Network, and Carolyn founding the Laryngeal Cleft Network. We're going to get into all of that during this episode. So do you guys want to briefly introduce yourselves?
Sure. As you said, I'm Caetyn Groner. I am a pediatric SLP out far in West Texas, and my son has a type 1 laryngeal cleft, and he has some other diagnoses as well. One of them is FPIES, and so it made this whole thing very confusing, getting all of his diagnoses straight and figured out. And I serve on the medical advisory board for the Laryngeal Cleft Network.
And how about you, Carolyn?
Thanks for having me, Tovah. I'm really excited to be here. I'm Carolyn Schultz. I'm the co-founder of Laryngeal Cleft Network, along with Deb Bachman, who's another parent. My son was born 21 years ago in Montana with a type 3B laryngeal cleft, which was a real challenge. He ultimately ended up in Boston for his care, and he was able to have his cleft repaired endoscopically as a toddler. However, when he was in his late teens, the top reopened. And so we had to go through it all again. He ended up having an open repair in 2023. And after that, we had to isolate in our home for about 8 months. We chose to allow that repair to fully heal. And during that time, I realized that all of the challenges we had had when he was a baby, parents were still facing that with this diagnosis. And I was so amazed that there was no nonprofit that had been established to help this community. So I talked to Deb Bachman about that, and we decided to start up Laryngeal Cleft Network, which we did last year in 2024. And we launched the website in October. So happy to be here.
I'm happy you're here. And do you want to share a little bit? Because I know, Caetyn, you mentioned your son had a type 1 cleft, and then you mentioned, Carolyn, that your son had a type 3B. So for people who aren't familiar with even what a laryngeal cleft is, if we could just give them a little background.
Yeah, so laryngeal cleft, everybody's familiar with a cleft lip. You can see it. It's a division in tissue. But a laryngeal cleft is a division in the tissue between the esophagus and the airway. So depending upon how deep it is, we grade it. There's 4 different types, with type 1 being the most mild, and that's isolated still to the larynx. As it goes deeper, a type 3B has gone beyond the larynx into the trachea, and then a type 4 can go down the trachea, even into the bronchi.
And it's tricky to diagnose.
Yes.
You can't see it, and so you have to know it actually exists to be suspicious enough to order all the testing that's required. It's really tricky.
One of the themes that I have found working with different families and then just talking with different families in different parts of the country is a thread that parents really had to advocate and push for more information and feeling stuck, and how tricky it was to get to the point of diagnosis seems to be like a common theme. Is that what you found too?
Yes, at least in my son's journey specifically, I mean, I knew all the things to look for. I work
Yeah.
with dysphagia in pediatric populations. I'm versed in all of it. My oldest child had laryngomalacia, so I knew the sounds of abnormal breathing. But it from birth to he had symptoms at birth, and then we didn't get his diagnosis until 15 months old, and he'd been symptomatic the entire time, and that was such a challenge. And it's such a challenge to continue and be that advocate every step of the way when you feel like you're not being believed, or maybe you're seeing things, or maybe things aren't as bad as you think they are. And looking through my journal and notes that I would prepare for our physicians before any, pediatrician appointment or specialist appointments in preparation for this podcast, I'm like, wow, those were crazy symptoms. Those were so impactful of every day and what we lived through. It was crazy to revisit some of those symptoms.
What were some of those symptoms?
Yes. So for my son, and I hear this a lot, the coughing, choking, red eyes, poor feed tolerance. When my son was really young, a few weeks old, we were still trying to nurse. His latch was beautiful, but he would just fall asleep immediately. He would suck, 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 have this great latch, and then just go from awake, active feeding to asleep. And it's hard to explain that to people who aren't necessarily feeding experts or don't know a lot about infant feeding, but that state change is a sign of distress. And it was hard to explain that, no, he's not just sleepy. I don't need to try again in 15 minutes. He's out cold from distress. So that was the early issues we had, but then a tracheal tug, neck retractions, rib retractions, perioral cyanosis, so blue around his face. The inspiratory stridor that I heard with my older son, I heard very much in my youngest. So I was assuming a lot of laryngomalacia for him with the breathing signs. But then the coughing and the choking just got so much worse with time. I also noticed that after particularly bad choking events, either on his reflux or on his bottle, he would get a fever about 24 hours later.
Wow.
And it was never bad enough to get testing for viral things, but now we know he was aspirating. But those were some of the signs. I think the scariest ones that stuck out to me most and started to get people's attention were when he would stop breathing from choking on his reflux. So even when he wasn't eating, this was happening. And that was really scary to deal with as a mom, because I don't have suction. I don't have tools to deal with that. I have tools to help him eat, but the breathing was a little bit different.
And how about for you, Carolyn?
Yeah, so right away, my son could not feed. We noticed that in the hospital, the nurses noticed it, but in those early days, you're just like, okay, they're getting some colostrum, you're told to not worry about it. So I didn't. But when I took him home, I got really worried very fast, because he would swallow maybe twice, cough, stop. That's it. Like, he could not eat. We had just moved to a new community, and I took him right away to the pediatrician and said, my son can't eat. And, I heard a lot in those early days of like, oh, there's immature swallows that babies grow out of. So a lot of providers were really well intentioned and just trying to be reassuring me with that information. So I listened and, took him back home, but the same thing was occurring and it wasn't getting any better. And it's kind of a blur. But within that first week, I was at the pediatrician's office twice. And the second time I went in, I said, can I please feed him in front of you and show you what's happening? And unfortunately, he declined that. And he then said a little bit forcefully that I see no red flags here, and I don't want you to bring him back for at least 2 weeks. So I got in the car, cried the whole way home, because I was desperate. Like, my child could not eat. And luckily, I had a friend who was a SLP. I called her. She came over. She watched him attempt to eat and was very worried. And she said, you've got to thicken his feeds. So I immediately got formula, Advent bottles, a box of baby cereal, and a sharp knife.
Mm.
And, I had no guidance. This was in
This
Montana
was 20 years ago, right?
20 years ago. I like kind of joke about it. It was the Wild West. There was no feeding therapy offered to me or that I even knew of. I don't know if it existed, frankly, back then, but we certainly didn't have it. And like every bottle I made, I was just like, all right, let's dump in the oatmeal and try and get it thick enough. And I got pretty good at it actually. And it was, I called it a sludge consistency. I think it would probably be pudding. And I don't know about the more recent categorizations of what it would be called because I have no experience with that. But he was at least able to eat that way. And actually, he developed really strong oral muscle through having to suck that sludge out. And he could, I think this is sort of funny, he could whistle when he was 10 months old.
It's really funny you mentioned that because I noticed my son could whistle yesterday. And he's
Really?
so
Yeah.
We need to do a research study on laryngeal clefts and whistling. Wow.
Yeah.
Whoa.
So we have come a long way in some areas when it
Yes.
comes to intervention and ITSE testing and swallow imaging and different bottle nipples that are available.
You know what? When that doctor told me don't come back for 2 weeks, I see no red flags. This was in a small town. There was one other pediatric office, and I immediately called them and went there, and they immediately ordered a swallow study. Thank God. So it did take us 4 months to get to a regional children's hospital where they were able to diagnose him. They diagnosed him with a type 2, which, wasn't fully accurate, but at least they knew it was a laryngeal cleft. And I do want to just say too, you asked about the symptoms, like obviously the feeding was a huge one, and he just outright didn't feed. Like he wouldn't feed and have symptoms, he just didn't. But he also nearly died when he was 2 months old because he caught a virus and he had such severe respiratory distress suddenly. And I rushed him to the ER. And when I got there, his oxygen was 72. And they told me later, they escorted me out and there was a big team around him trying to stabilize him. And they told me later, had you been like 15 more minutes, I don't think we could have saved him. So that was really terrifying. And he wasn't diagnosed at that point.
Wow.
Yeah.
And for both of you, when it came to swallow imaging and seeing, okay, there's an impairment here, there are adjustments that we need to make. I'm just curious because I've also heard from so many families where even once they get to the point, and sometimes it's months, where they get to the point and they finally get the swallow imaging, and we see that there's a physiological impairment there. We see aspiration, we see it up till whatever level, even then it's hard to get to like, okay, well, now what? Like we can start to thicken, but like digging to like, why is this happening? And when you mentioned, Carolyn, even like, oh, it's an immature swallow, they'll grow out of it. I still see that even after a cleft has been identified. Let's just wait and see. Like some kids grow out of it. And you and I have talked before about those windows of development. And we have these windows that babies are primed to learn certain things like chewing or cup drinking and different things like that. And so from a physician lens, they might be thinking like, oh, they might, be stronger for the surgery, or they're thinking from a different perspective. Whereas as a speech pathologist, we can be the ones to advocate and say like, hey, we need to do a risk benefit analysis here because if we wait 6 months, like there's a lot of feeding development that happens in those 6 months. So there was a question in there somewhere and I went off on a tangent.
We're still experiencing that nowadays with providers, even surgeons, not just SLPs, recommending wait and see. That was our first experience as our swallow study showed he was aspirating, showed dysfunction. The SLP who completed it, we were like, there's no signs of neurological involvement. I mean, we're going through all the options. What could this be? And she mentioned a cleft. And so that's what helped.
What?
She mentioned a cleft. She mentioned, I mean, this is kind of the only thing left in my mind is something structurally wrong. with his swallow. And so that's what helped us move forward. But even with that information, we were told to wait and see later on after scopes. Our initial scopes, no cleft was found, no laryngeal malacia, everything normal. So when we
You
went,
mean with your initial scope, sorry, with a flexible scope?
no, we had I'm hesitant to call it a triple scope because it was not a full-blown aero team. It was just two. We had GI who came and did an endoscopy, and then ENT came and did the rigid scopes.
Okay.
But ENT found nothing, even though we were directly looking for a cleft. And then several months later, we went to an aerodigestive team for a second opinion. And yes, he has a type 1 cleft and laryngeal malacia and tracheal malacia, and surgery to fix those. The stitch repair, he had 2 stitches and a supraglottoplasty, and he's doing great. But that our first recommendations are exactly what y'all have been talking about, is the wait and see approach. And in children, at least in our case, in a family unit, that feeding dyad, I mean, we were all struggling. He was very dehydrated. His weight was poor. We were spending hours and hours every day feeding him, and that didn't serve him best. And exactly what you were talking about in terms of development, not just feeding. So kids learn so much about sensory needs, about social experiences. All of that happens when they're eating, and not only table foods, but bottle feeding. That was something that we're going through now with my son, is some sensory difficulties and reflex difficulties because we fed him in such a specific position and such a specific way to get him to be able to take just enough fluid to stay hydrated, that he's now having sensory struggles and not catching himself when he falls, some other things like that, because he wasn't able to move when he took a bottle. But yeah, it's more than just feeding development.
That's so true. I'm really glad that you mentioned that. And the other thing that I've tried to be aware of as a speech pathologist when I'm doing imaging is getting really specific about what I'm seeing in that swallow. So as an example, I did a recent swallow study, and this little girl has a diagnosed stage 1 laryngeal cleft that she was told they didn't want to repair at this time. They wanted her to do a repeat study. And so I made sure in my report that I said her swallow is consistent with the other swallow studies that she had. Her oral skills have improved because we've been working in feeding therapy. Her swallow has stayed the same, and the only impairment in her swallow is that laryngeal vestibular closure during the swallow. And it makes perfect sense that that is happening because of this stage 1 laryngeal cleft, and getting so pointed and specific in that report so that mom is saying like, oh yeah, they called me and they're going to schedule surgery. Because otherwise the ENT was thinking like, oh, and this is something that I've heard frequently as well. They're not necessarily having swallow impairment because of the cleft. And that can be true when there are other comorbidities going on. That can definitely be true. But if we can get specific about what we're seeing in swallow imaging, then that will help the team with the family to make the decision about whether or not to repair and when.
I think that's where one of the areas where families struggle is they don't know to ask for that. They don't know to ask for the swallow study in some cases. And then once we get the swallow study, they don't know what to ask for, what to look for, to communicate that with a therapist who's completing the study, and to have, in your patient's very lucky case, the same therapist both times, to where you can actually
It wasn't me the first time.
Oh, well, darn. But at least you communicate. The communication piece, I just feel like, can be missing. And we live in a smaller town, and so a lot of times our patients travel for swallow studies to different hospital systems. So when they were born, they were in this one major city, and then they come home and they go to this nearest children's hospital, and then the third one's going to be local because they're tired of traveling. And so there's so much inconsistency in terms of the specific provider's like skill with pediatrics. It's hard. Parents don't necessarily know to ask for that. And it's hard to explain that unless they have someone on their side telling them.
That's why we need the Laryngeal Cleft Network.
Yes.
What else can we do? Like, how can we help in that early diagnosis phase? What for like a caregiver who's trying to figure out what's going on and push for more answers, or an SLP?
I think for both, it's communicate with each other. So I feel like oftentimes once there's some degree of feeding difficulty in an infant or a child, a pediatrician is going to send you to feeding therapy and then hopefully order a swallow study and go from there. So most everyone, I think, has a speech therapist. So parents communicating with their therapist, like, this isn't working. We're not seeing progress, or I'm not seeing progress. What are you seeing? Just really having that open dialogue, that open communication, not being afraid to hurt your therapist's feelings, or clinicians asking those hard questions. Are y'all following through with these recommendations? Do you feel like you understand how to thicken the liquids? How is that going? Truly having open dialogue and not being afraid of it, because the child can't advocate for themselves, and the doctors who everyone's relying upon don't know anything unless you give them this explicit, specific information, exactly what you were saying with, here's the specific thing I'm not seeing change, and here are all the things that have changed. Really laying that out. I think communication is key in every aspect, especially parents and especially therapists.
And if I can add one thing to that, Tova, I think that a lot of providers have heard of a laryngeal cleft and they think it's super rare. Like the original stats are 1 in every 10 to 20,000 births. But recent studies have shown that in kids with chronic respiratory symptoms that need a rigid scope, it's up to 7.5% of those kids actually have a laryngeal cleft. So we're really working on awareness amongst the general public, parents, but also providers to consider this and evaluate for it. It could be occurring. Those type 1 clefts are so much more common than people realize.
Yeah, considering it as part of the differential. And I was going to ask you about that. That was perfect about, just the rise in identification of these clefts, and the numbers have gone up quite a bit just with advances in science. And
yeah, and another thing that I think is important is, so once people realize that this exists and they're looking for it, it is still a rare anomaly. It's more common than we thought, but it is still rare. And that means that not everybody has experience with it as a provider. So it's important to refer that patient to an experienced ENT who has seen this before and knows how to deal with it.
yeah, that can make a really big difference.
That was our struggle, is we knew we were at a great place and we knew we were with great physicians, but the trick was that person having experience specifically with type 1 laryngeal clefts and having successful surgical repairs and all the questions that we then learned to ask. That was key. Finding an aerodigestive team was key for my son's, not recovery, but surgery and repair, and he can drink thin liquids now. Having that aerodigestive team was key for us.
Another thing too that I don't know if people are aware, but this diagnosis and treatment is, at least it appears to me, to be fairly nuanced.
Mm-hmm.
And
oh yeah,
there is not consensus among ENTs in a variety of ways on how you're going to treat it, what you do about it. So I think it's important for people to know that different ENTs handle it differently. So you're not
that's really good to point out. And even the identification it's not standard. So for example, some ENTs will call it a laryngeal notch, but that's a stage 1 cleft. And so I think finding the more we can unite and come together with common language similar to ITSE, where we all know what we're talking about, and we all start to talk to each other about outcomes. And I'm finding better outcomes with stitch repair when they don't have an NG tube, or different things. Like the more we communicate with each other, the more we'll be able to help these families quicker and have better outcomes.
Yes.
And that's really the ultimate goal of LCN and our website and our Facebook group. We're trying to bring all stakeholders together in this community to have open communication, right? We have to identify what the problems are in order to solve them. So that's how we see ourselves, as just providing a space for our community to discuss these issues.
Yeah. And you were talking about treatment options and how there's variability in how different ENTs approach it. And I was talking about variability even in diagnosis, but can you talk a little bit about treatment options?
Yeah, sure. So I know that with type 1 clefts, feeding therapy is recommended by most ENTs, at least to try. That's a whole though can of worms in my book, because there's so many questions that our parents have about feeding therapy. Like, what kind of feeding therapy? How do I find a qualified therapist? How long should it last? Like, there's a lot to that. Beyond the feeding therapy, then there are endoscopic procedures. So endoscopic means through the mouth, there's no incision. A lot of ENTs will do a stitch repair. Some will do injections where they inject a substance into the edges of the cleft to plump up those edges. Some will do a combo. They'll do the injection first, and then they like to see how that impacted the child, and then they may make a decision based on that impact if they go on to a stitch. Others just say, no matter what, I'm going to do a stitch, so I'm not going to bother with the injection. They all have kind of a different method and experience with that. Luckily, the endoscopic repairs are usually really well tolerated by kids, and it's an overnight in the hospital. Typically, there's always exceptions, and most parents see their child is feeling pretty good after 2 to 3 days. Would you say, Caetyn?
Yes, that was our personal experience and posing the question in our community group. That's generally the feedback I got is, within reason, a few days, a couple of weeks, and then some on either end had, oh, immediately, no problem. We had pizza. Or the other end of, no, it took months to get my kid back to baseline. But most it's a few days, a few weeks.
Of recovery time you're talking about?
Yes, of recovery time, pain, not sounding gunky, not coughing as much, getting off Tylenol, Motrin, that sort of thing.
And one of the things on your website that is so profoundly helpful, you have so much research on there, and you have broken down into types of research and how to break down the research that I think could be really helpful for families and clinicians alike. And I was just wondering, because you mentioned the injection, the Prolarin injection, putting out there that that is a temporary measure. And I'm just curious if you're finding that ENTs are trending more and more towards the endoscopic repair.
In my son's experience,
Sorry, Caetyn.
we were recommended, the first group we went to, the first ENT we went to said, if I see a cleft, I'll do the injection first and we'll go from there. And so then the aerodigestive team where we are at now, that was actually their same recommendation as well. So we were prepared for that. We knew it was temporary. We were told that some kiddos will get the injection and it might last a little longer than it's generally does or expected to, and they can kind of learn to compensate with a little bit of help over that period of time. So even though it does dissolve, it can help them learn to compensate, was what we were told to in some cases. Some cases it doesn't work at all. In my son's case, it worked immediately. His swallow study was great. I think 2 weeks after, 3 weeks after we had a swallow study just to check baseline. And then we weaned off the thickener. Yeah. I mean, within days, he was on thin liquids. And
Wow.
6 weeks to the day. And they said maybe 6 weeks on the lowest end of it lasting, and then 2 months, 3 months for the longest end of the injection lasting. He was 6 weeks to the day, started coughing, aspirating, all the signs and symptoms.
Oh my goodness.
Immediate. So for us, it was very clear. And then the stitch repair was easy for us. But that it is a a wide range. I know Carolyn had something else to mention.
Well, I was just going to say, I think my statistics are right, but there was a international pediatric otolaryngology group consensus study on how to manage type 1 laryngeal clefts in 2017. And I believe the statistic at that time was that 60% of the ENTs preferred to just do a stitch repair and 40% were starting with an injection. I think that's accurate. And I did, but how that's changed, you know, that's older now, right? It's 8 years old. So how that's changed, I don't know. But I did want to say that, because Caetyn kind of brought this up, that there are a few studies out there where they say that there's a long-term benefit to an injection. And I just want to point out that if you really look at those studies, it's a very, very small minority. So I don't want people to think like, oh, there's a 50-50 shot that if my child gets an injection, this is going to be all they need. That's not what studies are showing. It's a very, very small minority of children. And when they say long-term, I think like in a lot of the studies, that's like a year. So
In my experience, I just anecdotally, I've worked with lots of kids with laryngeal clefts, and I think I've only had one who got the injection and then didn't. We weaned from thickener, and he never needed a repair. Weaned him from his tube. One case, and very unusual because he had a lot of comorbidities going on. But yeah, I would say that that is highly unusual.
it is unusual, but it's great for those families. I don't want to
Right, yeah.
discount that. Like it's amazing, right?
Wonderful.
But I just don't want people to get their hopes up and hold out for that because it's unlikely.
Yeah, and I think it's also important to point out, that's why I was clarifying with you about recovery time from pain and from a procedure versus recovery, because a lot of parents and even SLPs who aren't as versed in laryngeal clefts would think like, oh, we're gonna get this quote unquote fixed, and then tomorrow they're gonna like chug, a Gatorade. I don't know, depending on how old they are. And it is really important when it comes to that follow-up in feeding therapy after that, it's nuanced, like you mentioned, Caroline, and then there's also protocols that can guide us in how to wean from thickener.
Yeah,
Yes.
totally agree. And just because somebody has their laryngeal cleft stitched shut does not guarantee that they're going to be able to swallow successfully. So that makes it even trickier.
Yes.
One thing I think families, maybe parents understand, but extended family might not understand as clearly, or different providers, that I want to point out is that the child has a structural deficit. I mean, the cleft is there. And so they're trying to figure out and trying to eat with something that's not formed properly. And so they develop habits and unique oddities to their swallow that aren't going to go away by closing the gap. You have to relearn those things then they don't have a baseline for it. They were born with this. So that's where feeding therapy can take a while, is that you have to remap that swallow and make it functional for something that was dysfunctional. It's hard to explain that sometimes to all the stakeholders that are involved in a child's feeding and swallowing.
Mm-hmm. And I'm curious too, because you serve you're on the pulse of so many families across the country that have this diagnosis. And it's something I see, so I'm just curious if it's a thing. But difficulty with salads, like when it comes to introducing salads prior to the repair. I have a lot of babies that I see that they're diagnosed with a laryngeal cleft and we're on thickened liquids and we're working towards, a possible repair, and they introduce solids and it's like gag city, like really hard transition.
Yeah.
We are so unique.
What's that?
I say my son is so unique, and I've honestly connected with quite a few families who are similarly unique, and that we also have allergic disorders.
Oh, right, because you mentioned and you have rare FPIEs, not even FPIEs is already unusual.
Yes, he has atypical FPIEs, so that means he has IgE, which he's outgrown his IgE allergy, thankfully. But he had IgE allergies and FPIEs, and they all mixed in together. But a lot of the families I've been connecting with also have these allergic disorders, which makes us very curious about the genetic
Oh,
thing.
a lot of potential research studies that were thrown
Yes.
out.
So that completely derails solids when you have, at least with the FPIES treatment, you have to introduce one food at a time for days at a time. And yeah, so that personally, that derailed everything. I'd be curious what you've heard, Carolyn, about children without allergic disorders.
And solids.
Mm-hmm.
Yeah, my impression, this is not scientifically studied, is that fewer kids struggle with solids. They definitely do, but it's not as many. And I know for my son, he did not struggle with solids at all. And given the depth of his cleft, he was able to keep his lungs pretty clear once he had a G tube and a Nissen fundoplication to stop reflux, because his lungs were very compromised when he was 4 months old from refluxing and aspirating that reflux. I have the impression they're not doing Nissens nearly as much anymore. I know there's a lot of complications that can occur with that, but that really did protect his lungs. So it was a good thing for him. One thing I was just going to point out with my son, and that is occurring in other kids too, is, kids have this cleft, but there's differences in their anatomy still, obviously, right? There's other things that can be going on, different malasias and whatnot, but also they can have redundant tissue in that cleft area, which is what my son had. So some could have like a complete absence, I think, of tissue, but he had like extra, but it's like our doctor explained it, closing a curtain, there's still a gap there. You can't see it versus like a curtain that's wide open. And so I do wonder if that aided him. I'm sure it did as he was swallowing. I'm sure that helps, that redundant tissue. And that redundant tissue is also another reason why when you take a child in to do a rigid scope, that potential cleft area needs to be palpated with a probe, because it may look like there's no cleft, but you stick a probe in there, that tissue parts and there is a cleft. So that's really important.
I wonder if that's what happened to you, Caetyn, when you said you had your first scope and it wasn't identified.
I am asking at our appointment in 3 weeks. I've got lots of questions. My oldest actually had scopes because he's unique as well, but not quite as unique as my youngest. And so I was comparing their pictures and they all look the same to me. So I have such a lot of questions to ask our ENT and walk me through the minutia of it all. I had a mom reached out to me and some information she received that this area can be the size of like a pin tip. It's a very, very tiny area and tiny differences that they're working with. So I'm curious, and we'll follow up on that information for type 1s especially.
Send it to the group chat.
Yes.
We'll be very curious.
That keeps popping into my head on several of the conversations we have, that as professionals who read research and have in practice and deal with families, we're aware of this, but there's this thing called evidence-based practice. And it's not just research. It's not just talking about what the studies show. It's not just what this physician or SLP or surgeon or whomever has experienced. And it's not just what the family thinks. It's all three of these factors going into what treatment strategy, what things you should do for your child. So if parents are listening, I really hope that they take some of these thoughts that we've talked about and bring it to their team and say, here's what I think, or here's our other diagnoses. Why do we think these things work? I think with the Nissen procedure, you mentioned, Carolyn, that it's not being done as much. It was brought up to us for my child because he has persistent recurrent vomiting. And for us, it is not a great option simply because he has an allergic vomiting disorder. So he's going to bust it open as soon as they place it. But is it a great option for some families? Absolutely. But taking all those, not just the research, not just the clinician's experience or the provider's experience, and not just the family, but all three of those pieces are really important.
Yeah. That's why I think, again, the Laryngeal Cleft Network is so important because bringing all those stakeholders together, because
Yes.
it's very different for a physician who, like, so thankful for our physicians. They just get to spend way less time with patients and they don't get to hear all the little intricacies and the experiences that families have. And then, so to have families be able to connect with each other and be like, your kid does that too? Oh my gosh, did you get offered this or did they suggest that? And then to have them know then what questions to ask physicians and for physicians and clinicians to get involved in those conversations, like we can help each other. Well, Carolyn, you shared a couple of treatment options, and then there was another treatment option that we didn't get to cover yet that you had experience with.
Right. So if endoscopic stitch or injection doesn't work, then there's always an open repair that they can do, which is a super invasive, serious surgery that nobody wants to undertake unless it's absolutely necessary. And it's only for type 4s and a few type 3s. Generally, the endoscopic surgery will work for 1s, 2s, and a lot of 3s. With an open repair, they go through the neck typically. And you know, the cleft is actually kind of near your backbone. So you got to go through a lot of tissue to get there. And a lot of times the patient will need a trach for a period of time. My son had a trach for 8 months. He got a G tube again when he was 19. So he had the trach and the G tube. And that's a really tough surgery, I'm not going to lie. But thankfully, the vast majority of people with laryngeal cleft don't need that. But I just wanted to make sure people knew that that is another treatment option.
Yeah. How's he doing now?
He's doing great. He took an entire year off from college. He is back in college now. He's always been interested in being a doctor. So he's on the pre-med track. He's a microbiology major, really enjoying it. And he, you know, has such a unique perspective. So if he does choose to go on to medical school, I think he's going to be an incredible doctor. And whatever he does, if he chooses not to, growing up with this has a lot of impacts on a person, and I think grows a lot of strengths in a person and makes you more resilient and know what really matters in life. And so whatever he chooses to do, I know that he's going to be amazing at it.
Yeah, he will definitely have empathy. That's for sure.
Yeah.
So one thing that I wanted to mention, and it's something you talked about earlier, Caetyn, about, and I think you mentioned as well, Carolyn, like finding experts, you know, and making sure that people have this background. I want to throw out there, and feel free to disagree, but in some rural areas or some areas, you get your SLP and that's the first time that they're encountering this diagnosis. And for people who are listening to, who are like, I want to be able to help, but I just don't have that experience. My feeling is that the same way that we would have a family reach out for support, you need to make sure that you're reaching out for support with clinicians who are more versed in this diagnosis, that you have a line of communication open, that you're communicating with the aerodigestive team, that you're reading the research, and that you're not making decisions on your own, that you're seeking counsel. But it doesn't mean that, like, okay, you have to say no to this case, like you can't take this case. That's how I feel about it, but I don't know if you would feel.
Been that rural SLP.
Yeah.
Fresh out of grad school, I was the only feeding therapist in a small area of Texas. I was the only person willing to be a feeding therapist. And I happened to have experience in it from graduate school. But I certainly hadn't seen some of my rare cases ever. And there's a few people that I'm like, that's probably the only time I'll ever see this diagnosis because it's so rare. It's finding a therapist who has the tools to learn and knows how to reach out to someone, knows how to find a mentor, knows how to access the data.
And think critically, because regardless of the diagnosis, like you could have a stage 1 cleft and they're aspirating all the way up to purees. Like the staging doesn't necessarily indicate the function. And so being able to just take the individual in front of you. And when it comes to rare diagnoses, I mean, I'm many years in and I see diagnoses all the time that I've never seen before. But you see like, okay, who's this person in front of me? What are they having trouble with? How can we meet them where they're at? What's going on with the family? And then you take it from there and you seek out more learning and information.
Yeah. So using their team, a lot of these families have really good providers, but communicating with them and connecting with them and making sure you have all of their medical information. That is something that I really struggled with in small town areas, is I wasn't receiving all of like the data. So how
Yeah.
was I able to get a big picture from these massive hospitals? I wasn't being given all the information. So making sure your clinician has all the information, is willing to learn, and then as a clinician gathering that information and having open communication with the family about get their feedback, because they're very much a part of the journey. It's their kid.
Mhm. And most teams are really open, in my experience, to communicating. Like I've even Zoomed in when I've had families travel. I've Zoomed into meetings, team meetings in Boston or wherever. So sometimes it just takes knowing like, oh, I can ask to Zoom into that. And
Yes.
yeah, or like I can email your provider. That's okay. Like, yes, that's really good.
Yes.
And I
I
just
think that
wanted
was,
to mention too, Tova, that it's really important to have a team approach when you have this diagnosis. So, you need an ENT, a pulmonologist, a GI, an SLP, maybe neurology, maybe genetics, whatever the individual needs are. I have seen a couple cases where it doesn't seem to be a team approach, and that the SLP is sort of making decisions without communicating with the other specialists. So that I think is concerning. It does need to be under an ENT overseeing the whole team.
Can you give an example?
Well, I mean, I know of some parents who say that, my SLP says my son doesn't need a stitch because of blank, blank, blank. And I don't think that that's within their area of expertise to make the decision. It needs to be the surgeon and everybody communicating together. But so sometimes, yeah, I'm not sure how that happens. Maybe they don't have people who are experienced with laryngeal clefts that they're working with. And so it just sort of ends up happening that they're following the advice of just an SLP and not the whole team approach. I don't see it a lot, but I have seen it. And
Yeah.
I find that worrisome.
I know another question that gets brought up a lot in the group that you've brought to me before, Carolyn, is families feeling like nothing's really happening in feeding therapy, or like, is this normal in feeding therapy? And we can talk a little bit about that.
That would be great because people don't know what to expect. And then we do hear people saying, like, we're not really seeing any progress. We keep going to feeding therapy, and the kid may have not, the child's laryngeal cleft may not be repaired, or maybe it is repaired. There's a lot of variation, but when do you stop going to feeding therapy? Like, or when do you try something new? Because there are families who are struggling with not seeing continued progress, and they're confused as to what to do.
Mm-hmm.
I hear
You have
that.
things to say about that? Oh, okay.
Yes, I've got a paragraph about this.
Speak to us.
Yes, this is a challenge I hear so much. And I feel like we as SLPs experience as well, especially if you work in not just feeding. So at an outpatient rehab, you're going to see all sorts of different patients. And I don't know if parents necessarily realize that. You see articulation, so that's speech, you might see fluency, you might see social communication disorders, autism, language, you see so much. You see birth to 18 unless you happen to specialize in something. And there are clinics out there who are specializing in feeding therapy. But a little information about that. There's different types of feeding therapy. So when the three of us and aerodigestive teams generally are talking about feeding therapy for a child with a laryngeal cleft symptoms, their symptom is dysphagia, we need dysphagia therapy, which is a type of feeding therapy. Swallowing is part of feeding, but there's other types of feeding therapy. There's other ways other children and even one child with a laryngeal cleft may struggle in more than one area is sensory feeding or oral challenges. You mentioned, Carolyn, that your son ended up having a really strong suck. Well, that's something we work on is oral skills, being able to lateralize food and get food into your mouth. And that's a different type of dysphagia than what we're really referring to. All sorts of children with all sorts of diagnoses need different types of swallowing therapy and feeding therapy. And it's dynamic. It changes over time. So initially, my son really just needed to be able to get liquid into his body without it causing an allergic reaction and causing aspiration and all that goes with that. So he really needed a therapist skilled in dysphagia specifically. And there's a whole set of treatment options that we can do based on the different issues with dysphagia. We can do thickener. We can change the temperature of the liquid. That changes things around. We can change positioning. There's so many different strategies that we can do. But if we're working on sensory feeding, when the child really needs dysphagia therapy, you're not going to see change in the dysphagia because you're not working on the dysphagia. And I think families don't necessarily understand that, and they don't necessarily know to ask for that nuance. And this is where I get so passionate about the SLP having all the medical information, because there has been cases where I don't get a swallow study report for a child with dysphagia. So I'm unaware that that's what's going on. They've had all this background information, or I'm getting just the radiologist's report, not the SLP's report. And I know to ask for that, but the parent doesn't. So it delays things. Yes, I'm very passionate about this subject, and families knowing what to ask for. Ask your SLP, what are we working on? What strategies are we using? And why do you think that that's going to change their swallow? Or why do you think this hasn't helped their swallow? And in my son's case, the answer was he hadn't had surgery. He needed surgery. That's what fixed his dysphagia.
Mm-hmm. Yeah, I think for caregivers and for clinicians to make sure that the intervention matches the skill that we're trying to advance. Because a lot of times, and really using that pediatric feeding disorder framework, so thinking like, okay, medically, there is a laryngeal cleft, it has not been repaired yet, this is what their swallow looks like, they also have this atypical FPIES, check. And then we have our nutrition, okay, well, we are really concerned about weight gain per the RD. So we're thinking about this and like, what is their goal volumes and how much are they going to think about that? Okay, there's our second box. Then functional skills, like, okay, for some of these kids, they haven't had as much experience. So they do have immature oral skills or they have other things going on. So like, here's what we're going to do to advance texture or advance their oral drinking skills. And then that's our box. And then psychosocial, like there's a lot of stress with feeding because it hasn't gone well and there's like trauma for all of us here. So what are we going to do to reduce the pressure surrounding mealtime and make this an enjoyable feeding experience for everybody? And so I think if you use that as like a general framework instead of being like, well, I want this type of feeding therapy, because when you use that PFD framework, then you're thinking about everybody, every child, even a child with a laryngeal cleft, those boxes are going to look different depending on them, their age and their family and their comorbidities and all of those things, their care that they've gotten up until that point. So I think if we can like zoom out that way, and then that can really help guide intervention, because then we know like, okay, well, right now he sees the bottle and he's hysterically crying. So let's start there. Like, and mom's shoulders are like up here. And then, yeah, and sensory definitely like falling into one of those boxes too. But I think sometimes we get really like stuck on like, well, I do behavioral feeding therapy. Like I do like this specific training that I took therapy. And it's like, well, that's really nice, but there's a person in front of you that doesn't fit into a workbook. I also get very passionate about this. So yeah.
I think for parents, it's good to know that there's two sides, and we want to look for the therapist who's going to see everything and be able to look at your child as a whole. And if they may not have the skill set for every part, they can either learn or they have a partner with them that can help fill those gaps, or they can send you to somewhere else who might be more knowledgeable on the dysphagia, whereas they can help with all the other aspects. There's just so many nuances to intervention that are hard, and some of it's setting specific. Are you getting home health and your visits are in the house, and what does that dynamic look like? Or is it early intervention and you're getting it once a month? There's so many different factors that we understand as therapists, but I don't know that families are aware of, that they can ask for these things and they can ask questions or change if needed.
Can I interrupt you, Caetyn? Because you bring up such a good point, and I'm afraid I'm going to lose it. How can our families find a qualified therapist that can help them with dysphagia, feeding therapist? What are the avenues to find that? I get that question so much. I don't know the answer.
Mm-hmm. One thing that I would look for in a feeding therapist is somebody who isn't doing therapy to your child, but somebody who is working alongside you, and it's a conversation. You're the expert on your child. I'm an expert on feeding and swallowing. My knowledge isn't going to do anything if I don't know about your specific child and your family. And so making it a partnership versus this authoritarian model where it's like, I'm going to tell you what to do, or like your child's going to come and sit here and I'm going to do therapy to them. That's not even what feeding is. Like what you were sharing earlier, Caetyn, like it's social, it's cultural, it's, you know, and so I think finding someone who is partnering with you as a caregiver would be number one. And then just asking, I would just ask them, like, what is your experience working with children who have dysphagia? Like, can you talk to me about that? Finding someone who understands the swallow study report. Like if they don't even understand the swallow imaging, if they can't wrap their head around that, then it's going to be really hard to wrap their head around how to improve it. And for students or for newer SLPs who are listening, if you drill down on your normal anatomy and physiology, if you don't know normal anatomy and physiology, then it's impossible to build on that into when things aren't going well. So drill down, feeding milestones, normal anatomy and physiology, so that when something is atypical, you can identify it, and then you can start thinking about how are we gonna help.
So there's no like certification, right? There's no like dysphagia certification that would make it easy.
I'm sorry. Yeah, that was a really long answer to your question. And
no, that was really good to hear all that. That was very valuable. But I'm like, you need something quick and easy, like,
Yes.
and there isn't one, right? I'm just asking.
Okay. I don't think so. I think asking your physicians first. So the aerodigestive team would probably be your best bet, since they see the outcomes. They follow you and they know what you're looking for in terms of the swallow. We live 8 hours from our aerodigestive team. They might not be able to point us out on a map. So that's not realistic for my son. If I weren't in SLP, what would I do? Ask our pediatrician and say, okay, we went to this first place and I feel like they don't really know what to do. Do you have another recommendation? Or asking asking SLPs you do know, calling around. I think I helped one family. I did a Google search for pediatric dysphagia therapy in this small town, and that yielded a few results. And so my vetting was, okay, do they still live in that town? What are they practicing? What are they saying? How are they involved in this in any way if they're putting that information out there? Honestly, in this specific case, we found a university, and there was a lot of articles published in their town. I've never heard of the university before, but amazing that we could connect them with that therapist simply because the university had some publications about what they were doing in their feeding clinic. It's just digging for the types of information that we're talking about and asking others. I think personally, as an SLP, if a family comes to me and they're like, okay, we want an expert, we want the expert, at least for a second opinion, can you help me find someone? Like, absolutely. I would love, having been through what we've been through, like, I would love to help some family in that way. If there's someone else out there, even if it's you travel to them for a second opinion. Yeah, there's not a quick answer.
That's That's helpful, and I appreciate that. What about how long to stick with therapy? You know, if you've plateaued, what is a parent to do in that situation where that may be the only thing they have to work on right now is working with a feeding therapist? Maybe they've already had an endoscopic intervention, or maybe for some reason they're waiting. I don't know, but that's what they've got to hold on to right now, and they're not seeing any progress. What should they do?
For me, I go back to that pediatric feeding disorder framework. So I'm never going to waste a family's time doing the same thing week after week and expecting a different result, because that is the definition of insanity. And it is a waste of their time and their resources and their child's precious development. So that's not happening. But if we're not getting anywhere, then either, are we missing something medically? Is there an adjustment that we need to make from a nutrition perspective and talk to the team about that, or about scheduling? Is there a skill that we're still working towards, and like what other ways can we advance that skill, or can we pivot? And then that psychosocial piece, like, okay, like what is, if there's still like stress or aversion, like why is this happening and what adjustments can we make? So again, just going back to like, what is the barrier here to us making progress? Not like, oh, your child's plateaued, so we're going to discharge you from therapy. Like, no, do some self-reflection, reach out to the team. And I feel like I sound so mean, but I get very passionate about it because I really feel for these families who they miss out on so much time, because they're not getting the support that they need. So that is what I would say.
Okay, that sounds great, but also does there come a point where you just say like, okay, we're done for a while, we're going to take a break? Because some
Yeah, but
families
there should be a reason. Yeah, like maybe you've hit a point where you have worked with this family and they feel really confident doing all the strategies at home, and you are waiting for that repair. Well, then yeah, like maybe it makes sense to pause intervention, because there's nothing else for us to work on right now. Really, the only thing left is for you to get this repair and then come back, and I'm going to help you, habilitate, because they never had a normal swallow, but I'm going to help you habilitate your swallow. So yeah, that can definitely happen too. But again, if you would just, if the clinician and the family would like just think it through, like, well, what are we working on here? Like, what are we doing? Especially when it's a family that they're going to a clinic and they're doing the same exact thing in the clinic that the family is doing at home week after week. Like that makes me want to like peel my skin off. Like, what? That's not intervention. That's not even intervention. What is that? It's a home program. Let them go home.
We didn't get to the point of, because we know better as an SLP, but we reached that exact point you're talking about, Carolyn, prior to my son's repair was, okay, we have tried everything under the sun. We have a feeding tube now. So we have a way to get him safely eating and drinking. So that's no longer a concern. We have the proper thickness to offer foods. I know how to offer his water in different ways so he can practice that skill. I know how to offer solids, what solids we're offering, et cetera, et cetera. Like all those boxes are checked. We've not had any change in neurological development. His physical skills, which were behind, are now on track. Like every single thing is checked off. And the only thing left is this isolated problem, the cleft. And the answer for us was we just need the surgical repair. We took a break. I mean, there was nothing, we were just going to show up and chat, which is great, but that's not therapeutic.
Yeah. This is like a whole soapbox, but I think that if we could grab hold of like really empowering caregivers and educating them, like I know as part of your story, Caetyn, like you weren't even taught how to properly ITSE test. Like if we could really like grab hold of that, we would have shorter wait lists for therapy. We would have families who are feeling more competent as caregivers. Like it would be very, very helpful. They wouldn't be traveling so much to all these appointments, because very early on they could like feel good about what they're doing and keep helping their child at home.
Mm-hmm.
Sounds good. I think there's some areas to improve upon for our community and understanding. So I hope that people will come to our Facebook group and SLPs and families, providers, and have these discussions, because it's effective. Like we're going to come up with solutions. I know it.
Yes. I know I sometimes I get ranty about this stuff, but
No, I get it.
we're coming together for solutions.
Yes, it's so important though. And we see how it impacts the child's development as a whole when things are delayed or things are more traumatic than they necessarily could have been for the child, and then the family unit as well. I mean, it is so hard seeing your child struggle medically and have to endure different procedures and blood work and all these different factors that really it's beyond just being able to swallow water.
Yeah.
It's the whole picture.
Mhm.
So true.
That's part of feeding therapy, is the whole picture.
Yes. Yes. I love that. So one thing that a lot of families experience is even after this cleft is identified and repaired, there's trauma there from feeling like they were crazy or they weren't heard for so long. And so I'm just wondering, Carolyn, if you can speak to that.
Yeah, I hear that so much, and I personally experienced that. And, I label it as cognitive dissonance, where a provider is trying to, they're well intentioned and they're trying to reassure you and saying everything's fine, but yet your instincts are screaming at you that your child cannot eat. And those two are butting heads. That's an extremely difficult position to be in as a parent. It's really rough. And you don't know what's happening, but you just know that your child can't eat.
It is such a challenge. And especially if you're dealing with more than one potentially rare diagnosis, it's so confusing and so hard. And I absolutely experienced that as well with my son. Something that helped us and then led to me knowing I was with the right providers and he was in the right hands was I would take notes on everything, take pictures, and I still do because we're still searching for answers in some ways. But when I found the right people, they would say, I don't know the answer, but I hear you. And we're going to find out. Let's dig in. And that is when I knew I was in the right hands. So if looking for the right SLP maybe, or any provider really, I think that was pivotal to us, and that has now allowed me to heal some of that trauma that you're talking about, Carolyn. Is okay, there is something going on and it's not just my responsibility to figure it out now, it's theirs as well. We're on the same team.
And just having somebody acknowledge reality, that they may not understand what's happening, but we hear you. And yeah, that is a problem. Your child can't eat. That is an actual problem. Just validating that reality is huge.
Yes.
That's a really good tip for healthcare providers to take.
Yes.
Okay. So we are going to be linking to Laryngeal Cleft Network, your amazing website, in our show notes, and your Facebook group in our show notes, and social media. You're at Laryngeal Cleft Network.
Yes. Yep.
Yeah.
Facebook and Instagram.
Okay. Is there anything else that we need to talk about? I can talk to you guys forever.
Some other ways that people can stay informed, we do have a newsletter that they can subscribe to. I did want to mention too that the CARE study is being administered out of Boston Children's Hospital, and it's looking for the genetic causes of laryngeal clefts. We have a CARE study page on our website that people can go to learn how to see if they're eligible for the study and to sign up. We just had an informational webinar last weekend, and when we get the recording of that, we'll put that on that page as well. Yeah, so those are all the ways to just stay in the loop with communication. But I did want to just say that all of us at LCN are so appreciative to all the support we've received since we've launched our website. First and foremost, like we honor every single patient, like Caetyn was just talking about. watching your child struggle, and my heart just goes out to every single person born with this birth defect. It is a tough road, it really is. And I know that in time, that gap in when someone's born and when they can get this under control is going to shrink. And I want that to be really short. And ultimately, someday we think like this may not even be a thing with advances in genetics and all. So anyhow, we do have patient journeys on our website too that providers and families can go read and just kind of get a better idea of what families go through. So I encourage everyone to do that. I also just want to thank like the many parents who have reached out. Got a little mini army of them now. They're amazing. They're working on awareness and social media and advising us. And these people are in the thick of things too. Like their kids are sick and needing surgery and all this stuff, but they still find time to reach out and be a part of this movement. And I'm so appreciative to them. We also appreciate the providers that are attempting to help our community. They may not have all the information, they may not be super experienced, but they're trying, and we thank you. Some providers have specialized in this their entire career, and that's amazing. They're an amazing resource for our community. I like to also just call out our medical advisory board. They're very generous with their time and expertise. Caetyn is on there, and she's done so much, like writing blog articles and providing guidance. She's been amazing. And also, we're extremely lucky to have Dr. Rabar from Boston Children's Hospital and Dr. Rudder from Cincinnati Children's Hospital. Thanks to all of them. Our donors, I'm sorry, I'm going off here, but there's so many people in our community who are making this happen. And it's not a few people. Like we need everybody to come together, and they are. And our donors are helping us to be able to make all of this happen behind the scenes. So they're huge. And then just finally, my co-founder, Deb, she's amazing. She brings so much to LCN. She's just like so calm and loving and wise. She keeps me grounded. And our entire LCN board, who's like always working behind the scenes. You guys have no idea what all is going on and what we're trying to accomplish. And we're working really hard. And we just want to invite everybody to get involved, because we all need to work on this together to move the needle and make things better for people who are born with this birth defect.
Thank you so much for everything you're doing to raise awareness about laryngeal clefts, and for coming on today and all the time you took to prepare to come on today and to talk together. I really appreciate it.
There's one really important thank you also, and that's to you, Tovah. So thank you for having this podcast and inviting us onto this. This is huge. It helps us bring awareness and build our network in our community. And I appreciate all that you do for all of your patients and providers and everybody. So thank you so much.
Thanks, Carolyn. I'm just honored that you're here, and I'm excited that LCN exists because it's very needed. So yes, we're going to link all that stuff in the show notes, and also the travel grant. We didn't mention that. We're going to link that in the show notes too, because
Yes,
that's really cool
that
for
would
people
be
who need to
awesome.
travel to get help. Yeah. So yeah, thanks for tuning in, and we'll see you next time.
Okay,
Bye.
thank you.